So in terms of what we can do, so first of all, it's really important, I think, to find out for sure that these are fibroids, A, and I think they are, but also B, to find out that those fibroids, if that's what they are what's causing your problems,
Okay.
the bleeding, the pain. From what you're telling me, I suspect that's probably so, but I don't really know for sure. And I know you've had ultrasounds, and ultrasound is good, but I think really the best test is an MRI to
Right.
really find out what's going on in there. I know you mentioned that it sounded like there were 2 fibroids and one might be growing inside and outside. Ultrasound can give you an idea of that stuff, but it's not fantastic.
Okay.
Yeah. MRI will, make it all 100% clear.
Do gynecologists know about this procedure? Like, I was never even told about it. Like, I had to stumble across it myself.
Yeah, I mean, they know about it, I would say. It's hard to say. I mean, maybe some don't know about it, but, we've been doing this procedure for 25 years now, so it's not like it's, brand new.
Brand new to me.
Yeah. Basically, so we'd want to confirm, like I said, that they're fibroids and that it's the fibroids that are causing the problems. And 3, or C, I guess I was doing A, B, C, so C, we'd want to confirm that the fibroids that you have, if they're causing the problems, are something that we can treat with this procedure.
Right.
So MRI can answer all of those questions.
Okay.
So there's a couple, so assuming that these are fibroids, there's a few things that we can do. One of the things, and I'm not recommending one over the other, but just to let you know, if these are fibroids, we know as you get older and as you get towards menopause, your hormone levels will start changing your body. We know that they'll start to shrink and go away on their own. So you're 32, 31.
I'm 31.
So you may be looking at 20 more years of this. So I'm not saying that's what you should do.
Yeah.
But I'm just saying eventually,
I read it that it could go down.
You can expect that it could go down. The other end of the spectrum, you could expect that, another option, again, I'm not recommending it, is to have a hysterectomy where the surgeon goes in, the GYN goes in, they take out the uterus, problem solved. But obviously then, you can't have any more children and so on and so forth. Sometimes there's like an in-between option.
The miss something.
Well, they can go in and just take out the fibroid.
But the chances of them coming back.
There is a chance because potentially what can happen is that they think they've gotten the whole fibroid, but they're not really.
Yeah.
They didn't really. There's a little piece of it, and then in 5 or 10 years or whatever, you'll start to have the symptoms again.
Yeah.
But sometimes it's an option. Now it depends on where your fibroids are, how big they are, and so on and so forth. An MRI can really give some good information as to whether that's even an option for you. Either way, though, that's called a myomectomy, by the way.
Yeah.
So either way, with a myomectomy or a hysterectomy, that's an inpatient surgical procedure, probably looking at 4 to 6 weeks or so of recovery. So just to sort of factor that in. What we do is very different. It's not surgery. We don't actually remove anything. There's no cutting or anything like that. Instead, as we were talking about earlier, we go into some of the little blood vessels that supply blood to the uterus.
So, I thought it was like a catheter or something.
No, we do use a catheter, but it's
but you're using like I thought you had to cut me. I'm so happy.
we don't take. So at the end of our procedure, we don't take anything out. So your fibroids will still be there, but we cut off their blood supply. So it's sort of like, I always tell people, if you think of the fibroid as or in the uterus like as a flower, flowers need roots. Yeah. So we're cutting off the roots, basically.
Blood supply.
And they can't see the right. So they are you okay? Aww.
I don't have to deal with it.
Yeah. Do you have any? Yeah. Here. Here you go. Oh, okay.
Thank you.
Here. So like I said, so we cut off the blood supply, which means the fibroids can't grow anymore. Over time, they will begin to shrink and go away. So symptoms like pain, sometimes the pain that you described in the past, or sometimes people have frequent urination. I don't know if that's something you have. Those kinds of things will eventually get better. Bleeding, which it sounds like you have very heavy bleeding, usually gets better a little more quickly.
Like the first menstruation, it gets better?
Sometimes. It's a little hard to predict. Sometimes. And again, this is where MRI is very important. So not every fibroid will do well with our procedure. What we need to do, so if you can imagine, we're cutting off the blood supply to something. So it has to have a good blood supply in order for our procedure to be effective. So ultrasound can tell you how big it is, it can tell you where it's located to an extent, but it can't tell you how good the blood supply is. MRI is great at that. So that's one reason. So what I'm getting at is, I think we need to get you an MRI to find out exactly what's going on. And it will tell us whether you're really a candidate for this procedure. So if there's a strong blood supply to the fibroids, then our success rate is usually in the 90% range. If there isn't a strong blood supply, our success rate goes lower.
So based on the blood supply dictates whether or not I will possibly be a candidate?
Exactly. Yeah. Now, what I usually do is, we can order you an MRI, get the results, and then have you come back, and we can look at the MRI together. I can show you exactly what's there. It's a lot easier. I can certainly tell you over the phone, but it's a lot easier to actually look at it, and we can go through it. And then at that time, if you decide you want to go ahead with a procedure, we can, get you scheduled and, go from there. We'd also draw some labs for you. So just so you know, so we want to check and make sure your blood all looks okay. One of the things that can happen with the dye, and this is why we check this, is it can cause problems for your kidneys. So one of the labs we like to do is check your kidney level. I don't have any reason to suspect you have any problems, but it's something that we keep an eye on.
After getting the dye done, okay, so I guess kind of going back and forth. The dye that they originally want me to do, I guess you're kind of thinking that it still would be a good idea just because of the one test not doing it.
It might, because anything that we do will not have any effect on the full.
Do you know if the dye test that I'm getting done with the facility specialist, if that dye is going to any way affect my kidneys?
It shouldn't, because most of that is not absorbed into your blood. A little bit might be. It's when it gets into the blood, and that's where we are. We're in the blood vessels. Right. That's going directly and straight to your kidneys. You might have a little bit that gets absorbed, but it shouldn't. What the fertility person would be doing shouldn't have really too much, if any, effect on your kidney. So in terms of the procedure itself, we do it as an outpatient. So we do it here in this center. We have a procedure room in the back where we do it. You need to have somebody who can drive you because we're going to give you a lot of very strong narcotics and pain medicines. So you can't drive for 24 hours after the procedure. You'd have nothing to eat or drink from about midnight the night before. Usually we get started pretty early, say around 6 or 6:30 in the morning.
Oh, wow. Okay.
Most of the time we are done with the procedure, I would say by 9 in the morning, and the rest of the time is recovery. And most of the time for most patients, everyone's a little different, but most people are ready to go by noon or so.
So how long does the procedure take?
The procedure itself is anywhere
Or does it depend on?
It depends. It definitely depends on what we find and what we see. Anywhere from an hour to an hour and a half, plus or minus. We've had them take half an hour. We've had them take 2 hours. It's a little bit, So in terms of the procedure, so traditionally what we do is we go into one of the blood vessels in your leg. We have ultrasound and x-ray cameras to guide us. We actually watch what we're doing as we're doing it. And we get into those blood vessels that are feeding the uterus and the fibroids. We release, while we're watching under x-ray cameras, we release tiny little particles into the blood vessels that act to plug up the blood supply there.
That molecule, like
exactly.
Little thingies.
Now, that, as I say, with a good blood supply is easily 90% successful. Traditionally, we go in through the artery in the leg, which is called the femoral artery. It's about this big. It's a big old fire hose,
I saw
basically.
it.
So after the procedure, you need to lie completely flat for a few hours, and for the next few days, you need to be very, very careful and stuff. So over the past, because we have to let that seal out because it's a big artery, a lot of pressure there. Over the last couple years or so, we've actually been going in through a tiny artery in your wrist instead. So if we're able to go in through your wrist, not everyone is a candidate, but if we are able to do that, you'll leave with just a little Band-Aid on your wrist.
Wow.
After the procedure, you'll have a little wristband on for about an hour or so, and then you can do whatever you want.
That's crazy.
Yeah, I know. We go sort of up and down.
Crazy.
We watch where we're going with the X-ray cameras, and it's the same procedure. It's just that the recovery tends to be better, and that risk of complications is less with going
the
through
wrist.
the wrist.
I was gonna ask you.
Yeah, it's less. So a lot of people are moving in that direction. We've been, like I said, we've been doing that for the past few years here.
Wow.
And so for the procedure itself, whether we go in through the wrist or the leg, after the procedure, you're going to feel a lot of very intense cramping for a few days.
Is that like the fibroids?
It's the fibroids dying.
Like, okay.
Yeah, they don't like that we cut off their blood supply.
No,
That's how they're going to let you know. Usually for 3 to 5 days. So we're going to give you a lot of very powerful pain medication. Sometimes they'll make you feel like you have fevers. Sometimes they may make you nauseous. You may get constipation. We're going to give you all kinds of medications to cover all of that. With all that, you're probably not going to feel like working for, I would say, a good
I was going
week.
to ask you how long.
So if we do it Monday, we like to try to get procedures done on Monday morning if we can, because then we have the rest of the week to help out and straighten out any issues. So most of the time, if we can do the procedure on Monday morning, by the next Monday, most patients are ready to go back. Usually what we'll do is we'll see you the following Monday for just like a brief, checkup and see how you're doing. And I would say about 75 to 80% of the patients are ready to go back to work. So that post-procedure period, that's a lot of very intense cramping. Obviously, I've never had labor pains, but from what my patients have told me, it can be similar.
How long does the cramping last?
It'll come usually in waves.
Okay, so like contractions.
Yeah. And again, we'll give you a lot of medicine, so you're not going to be on your own. But it's not a fun time. Okay. So it's a good time to catch up on a good book or watch your favorite show or whatever.
Okay.
I've noticed, I think, that patients who go through the leg, the recovery's a little longer as opposed to the wrist. I don't have any data to support that, but just what I've noticed.
But both the leg and the arm are just successful as
they are
defeating the
exactly. You mean as each other?
Right.
Yes.
Right.
Yeah, one isn't anymore. Well, I would say this, just from a technical standpoint, as the person doing the procedure, once we get in to the wrist, even though it's a tiny little artery, some of the angles of the blood vessels and stuff, I think it's actually a little bit easier from the wrist.
The wrist. I was like, that's crazy. Like,
yeah,
I'm just like mind blown because I didn't obviously didn't see any procedure done or even.
Don't we have a video somewhere? We have a video with me talking.
Is it on YouTube?
It's on our website.
Okay, well I'm gonna ask them for the paperwork so I can look.
Yeah, it's on, I remember filming it, so it's out there somewhere.
I'm gonna look. I'm so excited. Okay.
So it's new. I mean, it's only been the past couple of years that we've been doing this.
That one.
So just to give you some background and get into some of the risks of the procedure itself. So our colleagues who are heart doctors, called cardiologists,
right.
Sometimes, frequently, they have to go in patients who are having heart attacks, very quickly and help those patients out. They have to get into those blood vessels. And it takes longer for them to get in through the leg. So over the past 10 years or so, they've been going in through the wrist. And so we just sort of expanded it. So one of the things that can happen, so their patients are very different from you. You're a young, healthy person with no risk factors really for anything. Mm-hmm. Their patients, first of all, they're all having heart attacks. They all have heart disease. They frequently have high blood pressure. They frequently smoke. History of smoking, all the things that you don't have. So they are very much at risk for having a stroke.
Right.
So theoretically, one of the risks of the procedure, if we go through the wrist, is we have to go by, we sort of drive past one of the arteries that goes to the back of your brain. Mm-hmm. So theoretically, it's possible that there could be a risk factor for stroke. Now, the way I think about it is that our colleagues who are cardiologists who've been doing this for 10 years in patients who are very much at risk for stroke, they're not seeing hugely increased episodes of stroke from doing this. So in someone like you, who's a very young, healthy patient with no risk factors, I think,
I just want to pray.
Yeah. So there's that. Now, obviously, if you're going through the leg, it's not an issue at all. The only other thing that's related to the wrist, going in through the wrist, and then I'll talk about risk factors for the procedure itself, is that rarely The way the blood supply in the arteries comes to your hand is you have two arteries that come down like this, and they meet in a little arc under your hand. You can't see it. You wouldn't know that it's there. Very rarely, there's a small percentage of people, probably about 1% of the population, that has two arteries that come down and they just give the blood out. They don't have that little arc. There's nothing wrong with you. It's like we all have a nose, but everyone's nose is different. There's nothing wrong with you if you have the arc or don't have the arc. The only thing is, for us, if we're doing a procedure on this artery here and you don't have that arc, you could, and something happens to that artery, you could potentially lose blood supply to that half of the hand.
But you guys was